Welcome to VTE, Why Does It Matter? In this episode, we're going to be talking about improving outcomes for patients with VTE. As we get started, I want to mention that this is a series that's supported by an educational grant from the Bristol Myers Squibb and Pfizer Alliance. And the views and opinions are those of the speakers and reflect the synthesis of science. Content should not be considered as the official policy of the AHA. I'm Dr. Erica Shore, an associate professor in the School of Nursing at the University of Minnesota. And joining me today is a distinguished multidisciplinary panel. Today, we'll be discussing what are the appropriate tools to use to accurately determine a patient's risk of developing a DVT or PE. And once diagnosed, what treatment options, algorithms, and corresponding safety and efficacy profiles are available to address the VTE. Venous thromboembolism, VTE, is a condition that occurs when a blood clot forms in a vein, and this includes DVT, deep vein thrombosis, and pulmonary embolism, PE. VTE is very common. While the exact number of patients affected by DVT or PE is unknown, the CDC estimates that as many as 900,000 individuals are affected every year in the United States. There are a growing number of risk factors that increase the incidence of VTE, such as higher rates of obesity and cancer, increased numbers of individuals over the age of 60, as well as decreased levels of physical activity and increased sedentary behavior. DVT occurs when a blood clot forms in deep veins, usually in the lower leg, thigh, or pelvis, but DVTs can also occur in the arms, especially in the presence of a central line. Duplex ultrasonography is commonly used to detect blockages or clots in deep veins, and this is the standard imaging test to diagnose a DVT. A D-dimer test is a blood test that measures D-dimer protein fragment that's produced when a blood clot dissolves, and it can be used to help rule out thrombotic episodes and help diagnose conditions related to thrombosis. Contrast venography is a special type of X-ray where contrast material is injected into a large vein in the foot or ankle so that the deep veins in the legs and hip can be visualized. And it is an accurate test for diagnosing blood clots, but it's also an invasive procedure. An MRI can provide images of veins and clots, but they're generally not used to diagnose DVT. A PE occurs when a clot breaks loose and travels through the bloodstream to the lungs. And since computed pulmonary angiography, CTPA, provides images of blood vessels in the lungs, it is the standard imaging test to diagnose a PE. Ventilation perfusion, VQ scan, can also be used to diagnose a PE when CTPA is not available, or when a CPTA test might be contraindicated for a particular patient. A ventilation perfusion scan uses radioactive substance to show parts of the lung that are getting oxygen, that's the ventilation scan part, and getting blood flow, the perfusion scan, to see if there are parts of the lungs with differences between ventilation and perfusion. Pulmonary angiography, starting again, pulmonary angiography provides images of blood vessels in the lungs and is the most accurate test to diagnose PE, but it's invasive. So its use is generally reserved for a smaller subset of patients. And similar to pulmonary angiography, MRI can be used, but it's reserved for certain patient populations, such as pregnant women or patients in which contrast material is contraindicated. In general, when patients present, they'll present with swelling, redness, and pain when a DVT is present. Signs and symptoms of PE can come on suddenly and commonly include chest pain and shortness of breath. But sometimes VTE occurs without any obvious signs, which makes it harder to diagnose and can also result in patients not seeking the appropriate medical treatment. Now that we've provided a brief introduction of VTE, I'm going to have each panelist introduce themselves.
My name is Ken Bauer. I'm a hematologist in Boston at Beth Israel Deaconess Medical Center, professor of medicine at Harvard Medical School, longstanding major interest in thrombosis and anticoagulation.
My name is Olga Sachdev. I am a vascular surgeon at the University of Pittsburgh Medical Center with a longstanding history of studying inflammation and different aspects of vascular disease, including in varicose veins and in thrombotic complications. As a vascular surgeon, we do have a lot of experience of dealing with patients who have deep venous thrombosis, as well as complications, including post-thrombotic syndrome and pulmonary embolism.
And I'm Snehal Bhatt. I'm a professor of pharmacy practice at the Massachusetts College of Pharmacy and Health Sciences in Boston, Massachusetts. And my clinical practice is in acute care cardiology, also at the Beth Israel Deaconess Medical Center. And just like my colleagues have already alluded to, I also share a similar interest and passion for the management of venous thromboembolism with the use of anticoagulants.
Thank you all. I think a good starting point would be, how are patients presenting? What do we see when they show up? And what types of symptoms might be overlapped with other conditions, and how do you rule those out to determine that it is in fact a VTE?
Well, I could start. I think deep venous thrombosis typically presents, swelling, pain, redness of one of the extremities. Typically, it is one leg. Occasionally, you see people with clots in both legs that are symptomatic, but typically it's unilateral. It's a myriad of different presentations. Some people just have, pain in the calf, pain in the thigh. Sometimes the pain with clots that are really high up can be even more localized towards the hip area. But, really pain, redness, swelling. Then, of course, if the clots wind up in the lung, typically it's chest pain, shortness of breath, the chest pain characteristically pleuritic chest pain, hurting when you take a deep breath. But, again, it can be insidious with people presenting with gradual shortness of breath. Sometimes people have anxiety, breathlessness if the clot burden is large. But, people can be symptomatic for sometimes, days or weeks and not either go to the doctor or sometimes even, be treated like they have, some kind of infectious process. But, that's the dominant thing related to the legs and the lungs. And, I think the issue of awareness on the part of patients has been an ongoing struggle to get people to recognize DVT and pulmonary embolism. Everybody thinks about the heart, chest pain, shortness of breath. But I think there has been greater awareness over time of VTE, but still we see many patients walking around with big swollen legs for weeks before they finally access medical care.
Yeah, and I think if I could just add to that really quickly is, I run a pretty busy venous practice here, where we will see a lot of patients with varicose veins who present concerned that they might have a blood clot. There is some evidence to suggest that very large varicose veins can actually increase the risk of clots, at least in those veins, which can then propagate into the deeper system. So increasing awareness is really important. But on the inpatient side, we'll also see patients who maybe are non-communicative for one reason or the other. Perhaps they're intubated, perhaps they are sick with, very sick from something else, such as COVID, as we've all kind of experienced. And on the inpatient setting, that's really where the index of suspicion for the practitioner and the people taking care of that patient really needs to be on high alert. For example, if a patient is intubated and cannot describe whether they're having pain in their leg, but might have some unilateral leg swelling, I think the index of suspicion has to be high in that circumstance.
These are great points that you both make. And I think this unilateral versus bilateral symptom presentation, when you see a patient who presents particularly with bilateral pain that starts with the onset of exercise or any type of activity, you start to think of peripheral artery disease and some of these other conditions that can look similar. So that patient education part is important and rolling that out. So we've talked about what does a patient look like when they come through the door, that there might be some ways that we can identify patients that are at risk and do some education and do a more in-depth assessment for those patients that are at risk. I mentioned a few things before: older age, over the age of 60, being overweight, smoking, having a previous DVT, any contraceptive pill or hormone replacement therapy, cancer, heart failure, varicose veins, others that you see commonly in practice?
Well, you're mentioning all the risk factors really for developing venous thromboembolism, and I think it is important to realize that VTE is a multi-causal disease. There is no single cause, and even with people with a well-defined risk factor, I mean, along with the things you mentioned, I think you mentioned birth control pills and pregnancy, and it's a fairly long list, but chronic inflammatory disease, ulcerative colitis, cancer, if it's active, age, obesity, more of these things add together, the higher the risk. I think, there clearly is a role for prevention in high-risk people. A lot of the focus there is in the surgical population. That goes back a lot of years to recognition of, major surgery, post-op immobility as being important risk factors. But, I think a lot has changed in surgical practices, that people have, major surgeries done almost in the outpatient arena with minimal hospitalization. So the whole, surgical prophylaxis picture in terms of how it's actually implemented has changed somewhat. I'm sure the VTE risk has gone down a lot too, just because people are mobilized very quickly, and the post-operative period is less, and mobility is a very important way to prevent VTE, to be active. But I think in medical patients, it's also an important risk group. They spend more time in the hospital. They tend to be quite ill if they get admitted to the hospital. And I think, appropriate prophylaxis in that population is important to reduce the burden. So a lot of the whole picture of VTE is preventable. I think there's known thrombophilias, family history, but that's a minority of people. But there are some common biological, genetic, some acquired risk factors, some blood diseases. It really spans the whole spectrum of medicine, across surgery, medicine, all kinds of specialties, who do surgery too, and rheumatological diseases, GI diseases. So it's really in a way an internist problem or a surgeon's problem too, the whole problem of VTE.
Great points that infection and inflammation do raise the likelihood of VTE, but there is some mitigation that's happening when patients have a shorter length of stay. They're getting up and moving around to decrease that likelihood.
I mean, and speaking from a surgical perspective, that's getting people out of bed and ambulating as quickly as possible is a major goal to try to help reduce those risks. But even with that, we will take extra precautions provided that it is reasonable to do so, whether that is giving VTE prophylaxis medically or whether it is, using compression devices while, before anesthesia begins, so that we can help reduce those risks is a major factor. But I know in my practice, I will oftentimes ask patients about their family history of clotting, because a lot of times you can find out information that they may not even realize. If you start to ask them, well, has anybody in your family had it? And they'll say, oh yeah, my aunt had it, my sister had it, my mother had, and all of a sudden now something that seemed like it might be pretty routine is turning into something else. So again, I think a lot of that index of suspicion falling upon that practitioner as they're trying to question a patient can really lead to a lot of important insights.
Absolutely. So more detailed, accurate, thorough assessment, including family history and a risk assessment. So once someone shows up and we suspect this is what's happening, what do we say about standard of treatment? Obviously depends on the location of the clot, the extent, if the anticoagulant drip is needed, or if they can go straight to an oral anticoagulant. What are your thoughts on that?
Well, the spectrum of options, obviously, of treatments has expanded greatly in the last decade. The fact that we are able to move away from, warfarin with the need for monitoring, dose adjustments, frequent blood tests, dietary awareness, lots of medication interaction has been transformed by the direct oral anticoagulants. Certainly for, outpatients who are, arguably who develop VTE as outpatients, who are in reasonably decent health in terms of liver, hepatic function, not morbidly obese or morbidly underweight either. The direct oral anticoagulants are amazingly convenient in terms of initial therapy, recommended initial duration after you document a DVT that needs to be treated, 3 months, maybe out to 6 months. Initial period of anticoagulation. So that's been greatly simplified. I think there are many patients who are more complicated because of, comorbidities and maybe higher bleeding risk, drug interactions, renal insufficiency, dialysis, and the list goes on, where, sometimes one needs to call up some of our old friends like unfractionated heparin, or even use warfarin still. There's still a place for it. Or of course, low molecular heparin can be used too. So we have a array of options for initial treatment. I dare say there are people with massive pulmonary embolism where there have been many groups around the world in developed countries who have developed approaches for, catheter-directed thrombolysis for major PE or even major DVT. They're clot retrievers, the interventional radiologists, our colleagues in vascular surgery, all have advanced techniques to reduce clot burden more quickly, which can be used in selected patients, who we think are not going to do well with standard anticoagulation. These are tough decisions because I think deciding who needs advanced therapies of people who present with clot burdens is not so clear. There are a lot of individual judgment calls, and many centers have created multidisciplinary teams, getting, interventionalists, vascular surgeons, cardiologists, pulmonologists, even hematologists involved, pharmacists as well, in terms of deciding as a group whether people should be taken to some of these advanced therapies. These are almost virtual consults. It's very hard to get all these individuals, but sort of having collective decision making.
Yeah, I could certainly echo a lot of that. And in fact, we just had in our educational conference this morning for our group a big discussion about interventions for pulmonary embolism as well as DVT. And they are difficult decisions, and they are kind of best made by a multidisciplinary team. And I think this is also a shifting field where, at one time, it seemed like it made a lot of sense to try to get the clot burden out of either the deep iliac system, venous system, or from the pulmonary artery. And dripping lytics was the best way, and now maybe suction thrombectomy is the best way. There's certainly a lot of strong arguments for just anticoagulating and not giving, doing any intervention at all, which can also increase other types of risks. So it's an area, I think, of rapidly evolving research, and one that, hopefully, if we kind of keep at it, we can come up with a set of guidelines that better reflect what clinical practice is currently and what is best for patients than maybe even those that are already out there. And I'd be interested to hear Dr. Bott's opinion about this.
Sure. I think that you guys have certainly very elegantly covered a lot of the therapy options. And, I think that I'm almost mirroring my role in clinical practice here as we talk about the diagnostics and everything else. As a pharmacist, I'm always sort of very interested in listening to what everyone else on the team is doing from a diagnostic perspective. It's almost like a mystery, every single patient. And so I kind of enjoy that whole workup and that thought process. And in the background, based on the diagnostic criteria or based on the working diagnosis, that starts to delineate in my mind from a medication therapy perspective, which options are going to be more or less likely. So the more likely where a patient has, say, hemodynamic instability, or the more the more we're leaning towards invasive-based therapies, in my mind, that's where our older tried and true unfractionated heparin becomes probably one of the most attractive options. Whereas, patient stability or a DVT, that's where the oral therapies can be used immediately. And Dr. Bauer covered the direct oral anticoagulants. All four medications are FDA approved to treat venous thromboembolism, although there's a little bit of nuance in terms of how they're labeled. So there are two that do not require any parenteral anticoagulation to be used first. So apixaban and rivaroxaban can be started as monotherapy. And there's plenty of data to show that those patients can be safely treated at home or straight out of the emergency department. And there's significant cost savings associated with initiating DOACs by avoiding hospitalization. Dabigatran and edoxaban are also FDA approved, technically require a 5-day or more course of parenteral anticoagulation per the United States labeling. Now, there is data to suggest that that can be shortened to less than 5 days, but still, technically, that's a big delineator in terms of the need to, based on labeling, use a parenteral anticoagulant first versus the ability to have the flexibility to start whenever you're ready with the other two agents. Low molecular weight heparin is also still a very attractive option, especially as a bridge to warfarin. Depending upon cost, for the most part, DOACs have become much more readily available and readily affordable, but occasionally you will have patients based on their insurance coverage. I feel like insurance coverage is like just a total guessing game. You never have any idea how much a medication will cost, and even based off cost, the affordability for an individual patient, that definition is very different, right? And so there may be some patients where warfarin is really the option based on affordability. And as we know, warfarin does require bridging in order to be initiated, can't be used as monotherapy.
If I could just back up for a moment regarding some of the diagnostic tests, actually, to help define the extent of the DVT, some of which I think, Dr. Shore, you already brought up. The one that we use, and probably everybody uses as the gold standard, is really duplex ultrasound, which will give you extraordinarily sensitive information about whether a DVT is present or not, based on, and you can, the amount of detail you can get out of an ultrasound is really quite remarkable. You can age a DVT, and really for those of us who read these types of studies, it is incumbent upon us to note the age of the DVT, whether it's acute, whether it's chronic, or whether there are indeterminate features. And that is an office-based procedure. That does not have to be fancy. It doesn't mean having to, now it is tech dependent for sure, but it is a very good way of making that initial diagnosis. And then some of the other things that were mentioned, such as a CT venogram, we may decide to get a CT if this looks like a really extraordinarily high burden DVT that might be extending into the iliacs, and the patient has evidence of ischemia, which is rare, but can certainly happen in very extensive DVT. That's where a CT might become useful. And some of the more invasive procedures are only things that we would do at the time of intervening. So for example, if somebody had a very extensive iliofemoral DVT with evidence of phlegmasia, for example, where we thought that there was now an overlying ischemia, then we might consider doing an invasive venogram with the intent to treat then and there, either with thrombolytics or with suction thrombectomy. And similarly for the scan. So there really isn't much role for a venogram just to make a diagnosis. Those diagnoses could probably be made much better by using a duplex ultrasound or by using a CT. Again, CT really reserved for if you're trying to capture the extent of a very significant DVT or VTE.
I think we've highlighted the complex decision-making process for treatment. Would you all say that it's just as complex of a decision for secondary prevention, for example, a patient needing a filter placed for future prophylaxis?
That's a great question. I will tell you that the number of IVC filters that we have been asked to place has dramatically gone down over the last, I don't know, 5 to 10 years. There used to be a period of time where we were being asked to put in filters on polytrauma patients who were going to be going back and forth to the operating room, and they didn't want to stop the anticoagulation or stop their prophylaxis. And certainly from data that we could glean looking at prophylactic IVC filter placement at the time of bariatric surgery, it's pretty clear that placing a prophylactic IVC filter actually does more harm than good. So we do not really place a lot of prophylactic filters. There are very, very specific recommendations for when an IVC filter should be placed. And we are mostly placing retrievable filters at this point. And really, most programs that place IVC filters that are retrievable are having some type of rigorous record keeping so that we can contact those patients and get those filters out before they create additional problems. And that's a big problem, because when you think about some of the trauma patients that we might be seeing and placing filters in, they may disappear. We may never see them again. So we have to be very careful about who we're putting some of this technology in, even though it seems like it's so benign. Sometimes it really isn't, and you can get some pretty bad complications from them. For the vast majority of IVC filters, they're perfectly safe and they're fine. But I just want to drive home that point. But every once in a while, they can really turn south and create problems. And so we really only want to be placing them in those patients who need them.
Great points to make, and that emphasis on difficulty with follow-up that can sometimes happen depending on the patient.
I mean, you get into another whole area. I mean, we've touched a little bit about, if you will, primary prevention, and really primary prevention really primarily is related to people being in the hospital and people undergoing surgery. And there's there's been a lot of interest, obviously, in primary prevention of the duration of prophylaxis, after, particularly not only surgery, where there have been a lot of studies over the decades of how long people should get prophylaxis and how long it should be used. I dare say a lot of that has changed because of the change in surgical practice. That so much is done non-invasively and people ambulate. So the number of people who go out of the hospital getting prophylaxis, probably even after surgery, has decreased. Medical patients generally, for the duration of hospitalization, and most medical patients warrant it, but then there too is question of people who are still at really high risk when they leave the hospital should get prophylaxis. That's still a open and fairly controversial area. But outside of that, primary prevention really in the general population, yes, really we don't do it in general. People are aware of certain risk factors like very long airplane rides, but by and large, some of these are pretty weak risk factors. So there's not a lot of primary prevention unless people have actually had a DVT before, in which case it's secondary prevention. The whole issue then of who's had a major DVT or PE requires long-term too has been an area that's been studied for many years. We have a lot of information about the natural history of what the recurrence risk is. We have pretty good ways to identify high risk people for a recurrent event. Anyone with a major proximal DVT that comes out of the blue or major PE out of the blue has a pretty high risk of recurrence. And now with safer anticoagulants, or at least candidates to consider long-term anticoagulation if they had a major venous thromboembolic event. Indefinitely long-term to prevent, a really high recurrence rate being mitigated highly effectively. I think for people with more clearly provoked events, the risk of recurrence after major surgery within, 1 month, 2 months of major surgery is pretty low. So there's people 3 months, 6 months at most can be, stopped. But, there are other considerations of intermediate risk factors. What do you do with people with multiple risk factors? A very morbidly obese person who happens to have a clearly provoked surgical event, or all the outpatient surgery going on. These, you'd say, are not major risk factors. So we're getting people who are an intermediate group, and the question is, do they have reason to stay on long therapy? Estimating their recurrence risk is not so clear cut, and we don't have terrific decision rules. It's easy enough to leave people on long-term anticoagulation, but it's not something you want to do for people who don't really need it. So that's a complicated decision. The whole issue of hypercoagulable workups come up, whether they're useful or not. For most patients, they're arguably not useful unless somebody has a very strong family history and you identify a defect perhaps. So we get into an area that leaves a lot of individualization still going on. There are good rules, lots of guidelines, but in the end, patient preference comes into play too, whether you don't leave on long-term therapy the rest of their life is what you're talking about.
From a medication perspective, I think one thing that does help a little bit here is that there are a number of options that can be used. I think in the warfarin only era, I think that was maybe a little bit more of a challenging conversation to have. Dr. Bauer already alluded to some of the challenges with warfarin therapy. I sort of summarize all that by saying that it takes a lot of work to make warfarin work from both our parts as healthcare providers and for patients as well. They really have to be very plugged in and integrated into warfarin management to make that work. With DOACs, there's added flexibility, not only with just the convenience, but at least two DOACs have two different dosing options for long-term treatment, apixaban and rivaroxaban again. So it provides us with flexibility to use either the higher intensity chronic dose or reduced dose. And we do have data that reduced dose DOACs were effective, and the safety, at least in one study, the bleeding rates were the same as aspirin. I think patients often think of aspirin as, oh, it's over the counter or it's safe. And we think of anticoagulants as having, massive amounts of bleeding, but antiplatelets and anticoagulants, at least with DOACs, there may not be that broad of a gap in terms of safety events. But more importantly, from an efficacy standpoint, the DOACs, at least with rivaroxaban and apixaban, I think give us the flexibility in terms of the different dosing intensity that we could use for patients.
I mean, that's absolutely true. I think the threshold for people who really you think need anticoagulation based on their recurrence risk, it has become considerably easier for those people to put them on long-term therapy and having those options. And I know in my practice, where a lot of people you talk to long-term warfarin, and the bleeding risk, it is a good option even for older people who are in relatively good shape to reduce the comorbidity of recurrent VTE. Because I think the morbidity of recurrent events can be substantial, both as DVT or PE. And really, the anticoagulants are so effective. They don't reduce the risk entirely, but you're talking about 80 to 90% risk reductions over time. So I think there has a trend to leaving many more people on long-term therapy who really need it. That's the big question. I don't like to do it just because it's easy, but I want to make sure they really, in my mind, need it. But people have different preferences too, and that's an important element in VTE and any medical decision. Talking about patients' preferences about recurrence risk versus bleeding risk, and doing annual updates as to whether their profile have changed. I mean, I've seen people over time who start having problems with bleeding of various types, chronic hematuria, where the risk benefit for some patients may change. So at that point, maybe you need to either lower dose or maybe get rid of the anticoagulant altogether. So, it's still the issue of, I think annual follow-up for these people. And as you mentioned, you need to make sure people can afford these medications, because some of our older patients get squeezed because a lot of the benefits they get for some of the pricing arrangements that have been made for commercial insurance don't exist nearly as nicely for older folks.
I think that was such a great summation of, and definitely when I'm putting someone or deciding to leave someone on lifelong anticoagulation, I know that at any moment that risk benefit calculation may completely change. And they're going to come off of that anticoagulant. But to get to the point of the cost is that I think it's always good to remember that there are some good low cost options. If you really feel like someone needs to be on something long term, but they can't, maybe manage some of the issues with the DOACs that we sometimes see. And I know we have a lot of patients like that in our practice.
Yeah, I mean, everybody's, think if you practice 20th century medicine, if you prescribe warfarin, I still have, very well-informed, people who, don't have any problems with their pharmacy benefits who actually still, they've been on warfarin for years and they actually like it. They feel like they get a gold star when they get an INR that's in range, or they just like the security. So people have different values. Now, I think it's a much harder sell if nobody's been on warfarin before and you start going through the whole process of going on warfarin and INR checks. But for people who've been on warfarin for years, some of them actually still like it and don't want to switch, for, different reasons.
Thank you. I think we've had a lively discussion. We've covered a lot of topics in relation to VTE. We talked about primary prevention in high-risk patients, hospitalized patients, and particularly post-op patients with reduced mobility. But as we discussed, a decreased length of stay is helping to reduce risk for those patients. We identified the importance of detailed assessment to identify common risk factors and to ask patients about a family history. We talked about how gold standard for diagnosis can be a duplex ultrasound, which can provide detailed information about DVT, and CTPA for PE. And other imaging can be used, but generally on a case-by-case basis. Treatment therapies for VTE are changing in regards to clot retrievers and anticoagulants, and there's some decreased burden to patients in regards to dietary modifications and monitoring of that effectiveness. But as we pointed out, sometimes having more treatment options can complicate that decision-making process. And so this is an individualized case-by-case decision, factoring in patient preference, particularly in regards to cost, adherence to therapy, and their likelihood of routinely following up with providers. This importance of this risk and benefit calculation. And lastly, definitely could benefit from a standardized set of guidelines for treatment and secondary prevention that reflect what's happening in current practice. I think we also need to stress the importance of educating patients to inform them about their risks and how to prevent blood clots, as well as impressing upon them the severity of the risk, and that blood clots, if they're large or multiple clots, particularly in the lungs, can obstruct blood flow and oxygen, which can cause death. So for them to know the seriousness of the situation. Thank you to the panel and to the American Heart Association. This series is available through major podcast platforms. To claim credit, visit learn.heart.org and stay tuned for future episodes. Thank you for joining us. This concludes our discussion today.